Up to a third of patients seeking primary care describe fatigue as a major problem. It results in roughly 7 million office visits every year in the United States, costing employers an estimated $136 billion annually in lost productive work time. But the diagnostic process is complicated by the term itself. When a patient reports feeling tired, they are using a catch-all phrase that can describe several distinct physiological states. To find a treatment, physicians must identify which of 4 categories the symptoms fall into. A patient might experience a subjective sense of weakness, where they struggle to initiate activity. They might have easy fatigability, meaning they can start an activity but struggle to maintain it. Others face mental fatigue, characterized by difficulty with concentration and memory, or an uncontrollable need to sleep. Because these symptoms can stem from anything from a common virus to heart failure, there is no single laboratory test that can provide an immediate answer. Reaching a diagnosis requires identifying the specific underlying cause. To do that, doctors use a systematic diagnostic funnel to rule out potential suspects. The widest part of this funnel is the patient history. A doctor will ask about lifestyle and stressors to begin filtering categories of disease from the very top of the process. The diagnostic path is determined by the timeline of the symptoms. Fatigue is defined as acute if it lasts 1 month or less, subacute between 1 and 6 months, and chronic once it persists for over half a year. Acute fatigue is most often tied to a recent recognizable illness, such as the flu, or a specific life stressor. These cases typically require little to no further evaluation. For subacute and chronic cases, doctors look for behavioral or environmental factors. They screen for sleep apnea by asking about snoring, evaluate for underlying anxiety, and review current medications for sedative side effects. This interview serves as a vital filtering mechanism, shaping the specific clinical tests that follow. Moving deeper into the funnel, the physical exam allows a physician to look for tangible manifestations of underlying conditions, such as evidence of thyroid disease or heart failure. If the exam doesn't reveal localizing symptoms, extensive laboratory testing is rarely useful. In these cases, random tests yield a low diagnostic success rate and often lead to false positives and unnecessary follow-up procedures. Instead, doctors rely on a targeted baseline panel. This includes a complete blood count, chemistries to check kidney and liver function, a TSH test for the thyroid, and age-appropriate cancer screenings. This targeted screen helps identify major metabolic or endocrine culprits. As shown here, a simple thyroid function test can confirm if an underactive thyroid is the source of the exhaustion. If the baseline panel reveals a specific abnormality, such as elevated calcium levels, the physician then branches off to pursue a precise secondary diagnosis. This evidence-based screening process successfully identifies the underlying cause of chronic fatigue in approximately 2/3 of patients. This leaves a challenging scenario for the remaining third of patients. Result. Clinically, this state is defined as idiopathic chronic fatigue, fatigue that persists without a known origin. A small minority of these patients meet the criteria for myalgic encephalomyelitis, or chronic fatigue syndrome. This condition is characterized by severe post-exertional malaise, where symptoms intensify significantly after even minor physical or cognitive effort. Even without a definitive blood test, medical experts recognize idiopathic fatigue and ME/CFS as real and debilitating conditions. Reaching the bottom of the funnel without a clear disease is a diagnosis of exclusion. This shift allows the medical focus to move from investigation to the active management of symptoms. Management of idiopathic fatigue relies on a supportive doctor-patient partnership. This involves scheduling regular check-ins and establishing clear goals for maintaining daily activities and relationships. For patients with depressive symptoms, clinical guidelines often suggest an empiric trial of antidepressant therapy. These can be effective even when the patient does not meet the full diagnostic criteria for major depression. If medication does not provide relief, doctors may recommend a trial of cognitive behavioral therapy or graded exercise therapy, depending on what the patient can tolerate. Before your next appointment, help your physician by tracking your sleep quality, your activity levels, and the exact timeline of symptoms. Ultimately, successfully managing chronic fatigue requires entering the diagnostic funnel as an active, informed partner with your physician.